Bismillahirrahmanirrahim. Now we are actually following some of the nephrology lectures. As a person of a clinical medicine or internal medicine, how much I have gained from my experience with this disease, with the diseases of nephrology. Another problem which is going on is, which we usually see in our clinical practice, is about the renal compromisation and acute decompensation of the kidney had been discussed previously. Now it is a scenario of something about the renal compromisation or decompensation. I'm Professor Syed Ali Haidar. I'm visiting professor of medicine at DYSFUNCTION Medical University. Now some of the terminologies I have previously told you that one terminology we are using here is azotemia. Azotemia means that it is retention of the waste products, nitrogenous products in the blood. It is the pathological terminology. Azotemia. It may be pre-renal in origin, or it may be renal in origin, or it may be post-renal in origin. The second type of problem is occurring is the decompensation of the kidney functions. If it comes in the hours to weeks, then it is known as acute renal failure. It may be a pre-renal in origin, it may be intrinsic kidney of the kidney diseases, which is called the renal in origin, or it may be post-renal in origin. Today, one scenario is given in which the decompensation occurs in months gradually. This is the time actually which is important for the definition of what we call as chronic renal failure. A 60-year-old businessman, known smoker and diabetic, hypertensive, and was on NSAIDs for osteoarthritis for many months, presented with the effort intolerance and the swelling of the face and the lower extremities for the last 3 months. The temperature is 100 degrees Fahrenheit, pulse was 65 per minute, blood pressure was 200 by 100, it is definitely higher blood pressure. This is stage 3 hypertension, and because of the scenario, and because of the target organ probably is involving here, this is hypertensive emergency. The anemia was positive, the pedal edema was positive. I said that. He had noted the swelling. First of all, is appearing on the face and then in the lower limbs. The reduced breath sounds at both lung bases are seen. Both lung bases were seen, and hemoglobin was 7.6 gram. This is lowered one, while MCV was 82, which is normal. Total leukocyte count is 7,500. Platelet is 1,23,000, slightly lower. The renal blood sugar was 210, is higher. Blood urea was 114. It is higher definitely. And serum creatinine is 4.5. So ratio of 1:40, which I said, creatinine to urea is definitely disturbed. It is the high ratio now. It means that it is destruction or pathology occurring inside the kidney, not before the kidney, that is pre-renal. It may be renal or a post-renal problem. Again, the sodium here is lower down because it is the salt losing type of a problem, is 128, and because of the fluid retention, 128 sodium. Potassium is 5.8, which is high, and chloride is 100, which is normal, but bicarbonate is 13. Normal is 22 to 28, which means this is acidosis and it is metabolic acidosis. Axis just showed the bilateral pleural effusion. Claustrophrenic angle and the basis of the lungs or the dome of the diaphragm, they are masked by the fluid level. And this is the periorbital puffiness or periorbital edema. The pedal edema he noted. Axial chest, the claustrophrenic angle is gone, and there is a curve or meniscus sign or Ellis's curve bilaterally present, and the heart size is enlarged, and it is compensating left. It is left ventricular enlargement, dominant left ventricular enlargement. Questions is there to give the differential diagnosis. What further investigations are needed to finalize this condition? And what is the most probable diagnosis? What are your lines of management? 4 parts. Now, these type of cases, they are those persons or my students or my friends or my colleagues who are entering in the FCPS Part 2 practical examination. They want these type of cases where the multi-system involvement was there. Because if you have these type of cases like diabetes, like for example, tuberculosis, which is disseminated tuberculosis, or myeloproliferative disorder, or lymphoproliferative disorders, or autoimmune disorders, or HIV-associated diseases, or chronic renal failure. Now, it is the topic which is easily handled by them because they are reading and reading and reading and reading. In spite of the examiner who is limited on the subject, definitely at that time, because he is a clinician, he knows what he has seen, that's all. Theoretically, the candidate is very, very strong. Practically, although weak, but his expectation for passing these examinations are more. But he knows every part of the subject. So differential diagnoses are all those conditions which can cause the anasarca. Coming in it, the diseases of the heart, diseases of the lungs, the diseases of the liver, diseases of the kidneys, and metabolic disorders, the endocrine disorders. These can all cause the anasarca. So this is definitely high. Swab data in this scenario is old. A male smoker and known diabetic and hypertensive. He has the effort intolerance, and there was anasarca and a febrile anemic patient, evidence of the pleural effusion. But the heart data is hemoglobin 715, lower down, normochromic, normocytic. Platelet is 1,23,000, thrombocytopenia. Blood urea is 114, serum creatinine is 4.5. So ratio was disturbed between the creatinine and blood urea. Its ratio is 1:40. Now its ratio is more than that. Potassium is high, 5.8. Normally it is 5 around. It is 5.8. Sodium was low and bicarbonate was 13, means that metabolic acidosis he is facing. Differential diagnosis is Uraemia or chronic renal failure. We will talk about it. And acute and the chronic renal failure, there may be possibility of the interstitial nephritis, possibility of the nephritic or nephrotic syndrome. As you see in the X-ray also, there is congestive cardiac failure, And the hypothyroidism can cause an asarca, severe hypothyroidism, and chronic liver diseases can cause the anasarca. Most of the diseases are here in present because you will see these cases. Often you will see. The mostly which actually coming out in our mind is the probably the disease is related with the renal system, because the periorbital edema and followed by the lymphedema, and then it is spreading. In spite of the consistent heart failure, where the edema first usually noted on the limbs, and then it comes on the face. What we have told by our supervisors are usually seen like this: the progression of the edema. Now here is most likely it is from the renal region. Most likely diagnosis is CRF or oblique uremia. Why? Because it is uncontrolled diabetes mellitus, known uncontrolled hypertension, evidence of an asarca, anemia, which is, we see it is normochromic, normocytic, disturbed renal functions, creatinine and urea levels less than 1:40. It is disturbed ratio, and it seems to be, it is, if you cut it down, it is less than 1.40. Predominant, it is predominant in the region. We don't know, we'll see it afterwards. Now, these are the terminologies which are important. I already said azotemia terminology, you use abnormal increase in the concentration of the urea and other nitrogenous substances in the blood plasma, Uraemia. Chronic renal failure depending upon the duration of the renal decompensation. If it comes in the months or progressive months or 2 years, then it will cause the chronic renal failure. Duration is important, and the parameters are different. Now, if this is the terminology we use as a duration-wise, chronic renal failure. If the chronic renal failure will involve 2 or more systems of the body, or it will become the multi-system involvement, then the terminology we use is uremia. The complex of the symptoms due to severe persisting renal failure that can be relieved by improving clearance. Multi-system involvement occurs in uremia is the clinical terminology, purely clinical, because the systems are involving from head to foot. Terminology of urea less than 400 ml urine output, and urea means it is, according to some book, it is less than 50, or according to another book, is less than 200, whatever it is. We are following which book, I don't know. Acute renal failure, compromisation of the renal function in days and weeks, and CRF, chronic renal failure, compromisation of the renal function in the months. Acute on the chronic renal failure means that the fluctuation of the renal function in the chronic renal failure. Exacerbation, the patient was stabilized with anything with the drug treatment or with the dietary measures and limitation of the activity. Now the functions are deteriorating in few weeks, that it is called acute on the chronic renal failure. Uremia is a chronic renal failure plus systemic involvement. That is simple definition of uremia. It is 2 or more systems are involved in the chronic renal failure. It is called uremia. Now toxins are manifolds. The list of toxins are there. That is the byproducts of the protein and amino acid metabolism, like urea, gonadal compounds like gonadine, methylgonadine, dimethylgonadine, etc., creatinine, octreotine, urates and hippurates, and products of the nucleic acid metabolism, and products of the aliphatic amine metabolism, and products of the aromatic amino acid metabolism like tryptophan, tyrosine, phenylalanine, and other nitrogenous substances like polyamines or myoinositol or phenols or benzoates or indoles. Those people who are appearing in the FCPS examination, they should learn, these are the toxins. Name it in front of the examiner, so he will become highly impressed that you have done. Other toxins are also described in new advances. Recent advances that it is advanced glycogen end products, AIDS, in diabetes mellitus, for example. They are themselves causing this a toxin. Inhibitors of the ligand protein binding and glucuronoconjugates and aglycons and inhibitors of the somatomidines and insulin action. There are substances in the blood which are inhibiting the action of insulin and somatostatin. They are also classified under uremic toxins. A long list is there. If one can, enlist these toxins, it will be highly impressive because there are a lot of toxins. You cannot remove one toxin. It may be 7, 10 or more than that. That's why the systems are involved. Investigations, what are the tests of the renal function, renal concentration test, specific gravity, osmolality of urine. Urine RE will show it. Creatinine clearance, that is the most important examination. 24 hours creatinine clearance, it will give you the GFR. Now on the basis of this GFR, you will classify the chronic kidney diseases. If it is more than 100, for example, GFR is more than 100 to 120, it will be classified as class 0. It means that it is normal. Below 100 to 80 around it, chronic kidney disease 1, and then between 60 to 80, chronic kidney disease 2, and below that it may be chronic disease CKD. It is classifying your class of the CKD will be 3A or 3B, because if it is less than 60 to 40, it is A, and less than that is B. And the fate of the chronic kidney disease class 3A is better than B. B is a worse one. Less than this 40, 30 to, you can say, up to 20. It is the chronic kidney disease class 2. It is class of the disease. So downgoing wheel going, whether you are going downwards. So the creatinine in this session, you can classify it in the chronic kidney diseases. Class 0, class 1 better, class 2 worse, class 3 more worse, class 5 more worse, and 5 plus is definitely. Class 4 and 5, they need the hemodialysis in any way. Even class 3, B will also sometimes we do the hemodialysis depending upon the potassium, how much potassium is there. In this way, the CKD, they classify it according to the EGFR. Then you do the serum creatinine, it's a rough marker, although it will underestimate. Serum urea, nitrogen or blood urea, it is overdiagnosed, may overdiagnose this condition. So all should be done. Serum proteins, microalbumin, creatinine ratio, and urinary casts describing in the urinary RE examinations. The causes of uremia, at one time it was diabetes mellitus is the number 1 cause. Nowadays, according to the SIUT, it is hypertension is the most commonest cause of uremia. Then comes the diabetes mellitus, then comes the glomerulonephritis, then comes the polycystic kidney or pyelonephritis, then obstruction of the infection in the kidney, and angiotic nephropathy. Now these two are more, diabetes mellitus and hypertension. This patient has been suffering from the hypertension and diabetes mellitus in the scenario. The clinical features of the CRF, it will involve whole body. I will say the whole body. Neurological, ocular, respiratory, metabolic, reproductive, dermatologic, endocrine, cardiovascular, hematologic, gastrointestinal, musculoskeletal. These persons usually visiting the OPD with these type of symptoms. More is the staging of the kidney or class of the kidney disease, more are the symptomatology the patient will have. Like for example, the neurological like fatigue, drowsiness, peripheral neuropathy, irritability, depression, decreased concentration, ability, insomnia, ocular like retinopathy, red eye, respiratory like uremic lung, where the inflammation is going on, pruritus and pulmonary edema, metabolic hyperglycemia, hypertriglyceridemia, hyperuricemia, metabolic acidosis. Reproductive like infertility, decreased libido, impotency, menorrhea, delayed puberty. Dermatologically, pallor, pruritus, dry skin, that is cirrhosis, yellow grey color, decreased perspiration and brittle dry hair. Endocrine, it may be associated with the hypothyroidism and hyperparathyroidism because you are excreting it, the calcium and phosphate in the urine. Then the parathyroid activity definitely will depend on it. Second reason is this, that the kidney has very important functions. It will convert into the 25 hydroxycalciferol into the 125 dihydroxycalciferol, which will, it is active vitamin D, which will absorb more calcium from the intestine and it will cause the demineralization in the bone. So it's actually this is why the vitamin D is affected and there is a secondary hyperparathyroidism occur in these cases. Even the more than that tertiary hyperparathyroidism, autonomous type of hyperparathyroidism can occur because it signals that the calcium is low. Actually calcium is not low. It is even high, but the parathyroid is sensing it wrongly. Now, cardiovascular system, every disease of the cardiovascular is involving hypertension, congestive heart failure, pericarditis, pericardial effusion. It may be the cardiac tamponade, which can occur. Long list of it. Hematological anemia. Usually any type of anemia occur, bleeding tendency, susceptibility to infections, and gastrointestinal nausea, vomiting, anorexia, GI bleeding are more commonly seen. Diarrhea, uremic fetor, that is the smell is very, very fetor in character. The musculoskeletal system is involved like renal osteodystrophy. Now this condition is a specific condition in which the bones are involving and osteolytic activity is going on, and it may be adynamic bone disease and renal osteodystrophy, even cysts are formed. Osteomalacia, it is may be associated. Osteoporosis can be there. Osteoarthritis fibrosa cystica is another condition. Osteosclerosis, soft tissue calcification, and retarded growth. Now remember, these are the clinical features if one can remember. Multi-system involvement. As far as CRF is concerned, at one stage, stage 1, GFR is more than 70, blood urea nitrogen is less than 65, 6.5, and creatinine is 110 micromole. Stage 2 is in compensation, stage of the renal. GFR is 50 to 70, 6.5, and blood urea nitrogen between 6.5 and it is less than 9, and the serum creatinine is less than 178. No any signs and symptoms except for the underlying. So do not deceive by this. I say already that actually the GFR we require. The serum creatinine will underdiagnose and blood urea nitrogen will overdiagnose. So GFR is the main clue which class or which stages it is staging. I have already said the chronic kidney disease will be classified in stage wise. Stage 0, 1, 2, 3, 4 like this. 3 and 4 according to stages. These are here they are elaborating stages. Nowadays we are doing the classes. Now chronic renal failure, I already said that the cardiovascular system is involved, and I have told you that any disease of the cardiovascular system you have read, probably it will occur in the chronic renal failure. Basically the atherosclerosis is accentuated. It will cause these problems. All of the problems are accentuated atherosclerosis, pericarditis and other things. In the chronic renal failure, hematologically, I said already about the anemias and bleeding tendencies and platelet dysfunctions that is causing the bleeding, and the relative deficiency of erythropoietin, because the erythropoietin, again I will say, is a factor which is releasing from the juxtaglobal apparatus of the kidney because it is disturbed, and that is why it is normochromic, normocytic type of anemia. You are not losing anything. Decrease the erythropoietin production, reduce their cellular mass, and survival time is reduced. Loss, increased blood loss, folate and iron deficiency. Any type of anemia can occur. It may be megaloblastic anemia, it may be microcytic anemia, but mostly it is normochromic, normocytic anemia. Hyperinsulinism will cause the thrombocytopenia. Neuropathies, different types, insomnia, tiredness, depression, asthenia, restless leg syndrome. This is very important disease. It is related to the CRF, but there are many causes of restless leg syndromes. The patient's legs are jumping during the night. He cannot explain what is happening actually. This is the fact of the RLS is concerned. Restless leg syndrome is a unique type of a syndrome. Renal osteodystrophy, I already said that it may be high turnover, it may be low turnover bone disease, a mixture of it. Renal osteodystrophy is a subject where there is bone loss in the middle phase, or it is the organic phase of the bone is lost. Osteoporosis can occur, osteomalacia can occur. So actually causes I have already said that is the elaborated that it is 125 dihydroxycholecalciferol, which is rather lacking. Here the urine DR, the casts are seen here. The casts are waxy casts or granular type of casts are seen usually. CRF, water and acid disturbances are there. Potassium, hyperkalemia, hyponatremia, calcium is low, phosphate is higher, metabolic acidosis, magnesium is higher. So you do the serum magnesium levels, serum aluminum levels. These are the markers of the magnesium or phosphate and aluminum, serum aluminum also. Trace elements are increasing in the blood. It means that the diagnosis of hyperkalemia is that potassium is more than 5.5. If it is more than 7 or more than 7.5, there are chances of cardiac arrest. changes in ECG, the hyperacute T waves in the precordial leads. And P wave is not definitely, it is not very well defined. You see the QR interval is shorter. So these are the changes in CRF in the different positions, in the different concentration of the potassium. Now here they are discussing the causes of hyperkalemia. Definitely it is the increased uptake, intake, rapid administration of potassium by mouth intravenously, drugs containing potassium, Chinese medical herbs, and impaired excretion, that is important. Chronic renal failure, if GSFR is less than 15 ml per minute. Or we can say that is chronic kidney disease of stage 5. So causes of hyperkalemia, shift of the potassium out of the cell, from inside to the outside, in acidosis, in tissue breakdown, and bleeding in the soft tissues, hemolysis, catabolic. These are the questions asked by the examiner. Why there is hyperkalemia, for example? This is the answer which is given. Diagnosis is case history, of course, and physical examination. Every system should be examined. General examination to the every examination. Musculoskeletal, nervous system should be examined. That is why the FCPS candidate want these type of cases. All systems are covered with the positive findings. Lab studies including urine analysis, urine function test, biochemical analysis of blood, X-ray, ultrasound, and the radiograph. Ultrasound will show the small kidneys. Treatment of the CRF is accordingly. It may be non-dialysis, just go for the correction of the potassium, the sodium levels, and so on, and general measures and the balance of the fluid. So the fluid should be given. It is restricted fluid. So 800 ml plus the renal output in 24 hours. For 500 ml plus renal output according to the severity of the disease. Proteins are restricted to very, very small amount per day requirement. It is hardly 0.5 gram, 0.2 to 0.5 gram per kilogram body weight per day. It means twice a week you can take hardly 100 gram of the meat twice a week in the form of the chicken or in the form of the fish. Dialysis, definitely hemodialysis, you will be doing the hemodialysis. You can go for the peritoneal dialysis. In diabetic patients, this is useful. It may be continuous peritoneal dialysis. It may be intermittent dialysis. So diets are restricted definitely. I already said about it. And one thing is more in advances in 20 years about the ketosterol. It is a Chinese medicine. It is actually the supplement they have given, and according to the Chinese scientists, it will reduce the creatinine levels. In my study of 100 patients, 60 to 70% are benefited from this ketosterol. So you can try it, it will not harm the patient. Reversible factors, hypertension, reduced renal perfusion will be definitely will be increased. Urinary tract obstruction will be relieved, can be relieved. Infection can be treated. Nephrotoxic medication should be withheld. The metabolic factor, calcium phosphate products should be withheld. Complication, hyperkalemia, you should manage it accordingly. Cardiac complication accordingly, because there is a big discussion then. And all systems are involving hematopoietic system. Only one thing is important in this case is the erythropoietin recombinant type. Should be given, it is 2,000 to 3,000 units, should be given twice or thrice a week. Or you can give 10,000 international unit thrice a month. Every 10th day you will inject subcutaneously. Target hemoglobin is 10 to 12 gram. hematocrit should be 30 to 33%. But erythropoietin will increase the blood pressure, so monitor the blood pressure. Hypertension is the main complication with the erythropoietin, hypercoagulability and thrombosis of the system. And the fistulas, for example, you have put the fistulas, artery venous fistula, it will be thrombosed if you repeatedly give this. So you have to give these patients at least the platelet inhibitors. So renal dystrophy can be managed with the low phosphate diet, calcium carbonate, vitamin D supplementation. And in some cases, the parathyroidectomy can be done if it is autonomous parathyroid. Actually, the last management in the end-stage renal disease is the renal replacement therapy, RRT. Go for the hemodialysis, go for the peritoneal dialysis either, or go for the renal transplantation. Now, renal transplantation is going on in the whole world. In Pakistan, it is limited to the people who are under 50 years of age and have got less comorbidities. And thirdly, they have got matching of their genes genetically to their brothers or sisters or first degree relatives. It will be successful, and people are having the renal transplantation done 30 years before they are still alive, and they are taking the chemotherapeutic agent to suppress the graft rejection. So hemodialysis, this is the type of the hemodialysis they are showing, and contraindications are those conditions, stroke or severe cardiac complications, severe bleeding, malignancies, poor condition, and you cannot do the hemodialysis, you go for the peritoneal dialysis. The continuous peritoneal dialysis in a child, old people, and diabetic patients are benefited from the continuous peritoneal dialysis. Ambulatory dialysis, CAPD, continuous ambulatory peritoneal dialysis. So these are indications which are there for the hemodialysis or the peritoneal dialysis. So these acute renal failure, how will you manage, and other systems are involved, how can you manage? A very long discussion, definitely. But you think that you have understood what do you mean by acute renal failure, what do you mean by the chronic renal failure, what do you mean by the uremia, what are the predisposing factors or the etiology of the uremia, what are the toxins which are causing this, what systems are involved, and how will you manage these cases, general measures, specific measures, symptomatic measures, preventive measures, dietary measures, surgical measures, should be write it down like this. I hope this is a long discussion, but I hope it is not boring, and some of the people can be benefited from this type of lecture or tutorial. Inshallah, we will meet again. Wama alayna illa al-balagh. Assalamu alaikum wa rahmatullahi wa barakatuh.